Well, thank you for coming here because we are talking a lot about American medicine, and a lot of countries base a lot of their medical systems on that of the United States. Unfortunately, because things are going poorly now in the United States, and I don't know if we're learning from our mistakes, but I hope the rest of the world will. Now let me give you a brief overview of what has happened and what will happen. They ask about financial interest. Well, I do have a financial interest in this because it's my livelihood. What about future financial interest? Well, I may not be around, but you will. Now, the United States has generally been considered a leader in innovation and advances in medicine and technology. Doctors from other countries come to the United States for postgraduate training. Oftentimes, they want to stay. And in my hospital, I would say at least half, if not more, of the doctors are of Indian origin, whether they were born in India or they're the offspring of those who came. Now, in the United States, we're not smarter and we're not prettier than people in other countries, so why do they come? The reason had been that we have a good symbiosis between academia, the government, and private industry, and lots of exchange of ideas. We welcome new ideas, we welcome innovation, and if someone fails in an innovation, they're not ostracized, they're just ready to go on to their next big idea with backing. That is significant in comparison to what happens, from what I understand, in other countries, especially in Europe, where it's a disgrace if you have an idea, it fails. No, you go on to the next one in the United States. A lot of these innovations, unfortunately, have occurred during war. Turing is a beautiful example. Code-breaking computers developed under his guidance at the advent of World War II, rockets, jet engines, and everything, nuclear power, in medicine, penicillin, prosthetic limb improvements. Women started to enter the workforce. We think of riveting Rosie the Riveter in the United States. They came out of the kitchen and they went into factories because the men were overseas fighting, and the women stayed. Question, can the United States maintain its lead? We have FDA constraints. Take a look at this. The cost of required studies for drugs and equipment. Things are approved in other countries before they are in the United States. We're overly concerned about adverse effects and misusage. Various examples. United States, we developed the LASIK, but we couldn't use it. We had to my patients went to other countries, Mexico, Canada. They were using the LASIK. Couldn't be done here in the United States until much later. Combinations of medicines, pharmaceuticals. No, you have to have it separate. So patients have to put in all these different eye drops instead of a combination that they have elsewhere. IOLs, all these new styles. Europe, even India, they're using it. They're investigating it. No, only recently have toric restore lenses been approved by the United States. What are the constraints? Lawyers. They smell money and adverse effects. Advertising on TV, 1-800, bad drug. All this adds to the expense. Now, we have in the past we had a two-tier medical system. We still do. The top T, as was mentioned, fee-for-service, Medicare for patients over 65, deductibles and co-payments, insurances, but we could not charge over and above the insurance allowed amount, unless you had the premium services that you mentioned. Then there's the lower tier, economically disadvantaged. We had public hospitals and clinics, and frankly, these were facilities for training residents and fellows. A lot of clinical material, a lot of it was done for free, government paid. It was wonderful. Then the government said, these poor people have to be treated by private doctors. So they sent them to the private doctor's offices, and our training facilities suffered. And Medicaid paid 75% less than the top tier payments. And insurance companies would only authorize what they felt was needed. So here's upper tier services. This is the treatment that the upper tier get. Certainly first-class service is my office. And now take a look at the lower tier. This is how it goes. My technical assistant becomes a London Barbie. All she does all day long is tell me where to go. Literally. And this is real time, not necessarily. I think you get the point. Now, they're expanding the two-tier system medical care. In the present, the top tier is shrinking. As insurance premiums go up, deductibles and co-payments increase, and the lower tier patients are being transferred to health maintenance organizations, or HMOs. Two types. One is capitation, where you get a set fee for every patient per month, whether or not you see them. So that means the more patients you see, the more it costs you. The fewer patients you see, the better off you are. And then there's the fee for service, also regulated by the HMO insurance companies. But the pressure is on you to join these, and they pay even less. And patients must have authorization for each and every specialist visit, even if frequent visits are necessary. Every procedure you do, even a Schlesian, needs authorization. Why? They think it lowers the cost, but it doesn't, because they have too many bureaucrats that are being paid for doing what? Approving things that are needed, and not even doctors. It says that that it promotes healthy lifestyles and preventive medicine and early detection of disease. Bull. So in the present, we have HMOs. They have the enticements for people to enroll. No annual fees, no deductibles. You even get gymnasium privileges. My 90-year-olds could join the gymnasium. And patients are told some restrictions may apply, but they don't specify, and they don't talk about the authorizations. And the lower tier, they're being forced into HMOs. They take those on Medicare and Medicaid. And patients don't even know that they're going. And that includes Obamacare. Oh, sure, Obamacare came. Everyone, or almost everyone, has insurance. But because of this, they have insurance, but are they getting medical services? Because a lot of doctors are not even caring to care for them. The fees are too low, and all the authorizations. Authorization. I tell my patients, you can't die. You have to be authorized. So who does these authorizations? Committee of Primary Care Physicians or some desk clerk? The decision makers have a vested interest in not authorizing the referrals and treatments because patients are seen as unprofitable. And here's a cartoon. Your respected physician with lucrative HMO contracts. How could you go broke? I started treating my patients. Or under capitation, the only way that a physician makes most money is not treating the patients. Well, it gets worse. Here's the breakdown. We have, for these HMO patients, the lower tier that are going, they're put into HMOs. We have various ones. We've got IEHP, Molina, Care First. Okay. But then there's interaction between the two, unknown to the patient because they don't speak English. They don't know how to read. Well, some do. They could be transferred from one to the other. So that means that they're transferring the doctors. They don't know. They show up to the doctor's office, and they can't be treated, or we have them scheduled for a surgical procedure. We can't do it because their insurance changed the next month. And my staff spends all its time now, even while I'm here, getting authorizations, checking to see if they're still authorized, see if they're still eligible, because what's happening is even in some of these broad HMOs, they have subdivisions like Vantage, AlphaCare, and other IPAs, and they get shifted back and forth, and they don't even know it. So they could be approved for this, but not approved for this. This IPA says yes, but this one that we just moved over says no. And so are patients getting care? No, they're getting the runaround. And that means that at the last minute, we're canceling a set of surgeries because they're not covered. And then we have overbooking in the office. And what happens? They all show up and we're working until very late at night. Patients waiting 3-4 hours, because if we don't do it that way, they wait months and I'm sitting around doing nothing. This is because of the American system. Here's the structure of the HMOs. We have government, corporations, all these little subdivisions, discounted fee for service, and in an organization you can have all types of specialists, and in ophthalmology, retina, plastics, general, but I have to get an authorization to refer to a subspecialist. Then we have all these other HMOs and insurance companies, and there are some doctors who belong to several of them, and you have to. And again, under capitation, as I said, you make by not seeing patients.
Dr. Schultz, time is up, actually.
Okay, let me just finish up here. So managed care balances the quality and cost, but studies have not shown that. And then they throw you out. Could it be good for India? No. Aging population, increased. Can we trust the government to be honest? Even if the gatekeeper is ethical, they're under too much pressure. So what's the future? Computers? Maybe they could do so much better, and this is Turing. IBM, they sent their computer Watson to medical school, and their half-life of existing knowledge in medicine is now down to 8 years. So you need computers right now to do all this. They can read everything and judge what a patient needs. Here's a clinical example that a computer can get everything and digest it. And in a previous talk, and also in the general sessions, computers may very well be the future doctors. As the robot says, R2-D2, thank you, including me as a healthcare provider.
Thank you very much for your illuminating talk.